Okay, so welcome everybody to today's event. My name is Claire Westmacott, and I am the Manager of Knowledge Translation and Programs at Parachute. Before we begin today's webinar, I do want to begin by acknowledging the land on which Parachute is located. For thousands of years, it has been the traditional territory of the Wendat, the Anishinaabe, Haudenosaunee, Métis, and the Mississaugas of the Credit First Nation. Today, this land is still the home to many Indigenous people, and we are grateful to have the opportunity to work on this land. And while we meet today on a virtual platform, we encourage all of you to take a moment to acknowledge the importance of the lands which we each call home. From coast to coast, we acknowledge the ancestral and unceded territory of the Inuit, Métis, and First Nations people that call this land home. So welcome everybody to today's webinar. My name is Claire Westmacott, and I am the Manager of Knowledge Translation and Programs at Parachute. Parachute is pleased to be hosting today's webinar, Trends in Canada's Drug Supply, Polysubstance Use, and Unintentional Drug Poisonings. Parachute is a national injury prevention organization committed to preventing serious and fatal injuries through evidence-based solutions. In Canada, poisoning is a leading cause of injury-related death, and Parachute is proud to work with many partners across Canada on poisoning prevention and response. Today's webinar will focus on unintentional drug poisonings, which remain one of Canada's most devastating public health issues, affecting families and communities across the country. So from the Canadian Centre for Substance Use and Addiction, today we have with us three presenters, Chealsea De Moor, Emily Biggar, and Doris Payer. During this session, our speakers will provide an overview of emerging trends in Canada's unregulated drug supply, polysubstance use, and harms related to unintentional drug poisonings. Our speakers will also be highlighting implications for reducing harms to people who use drugs and practicing non-stigmatizing language around substance use. And before I introduce our speakers, I do have a couple of quick housekeeping items. So this webinar is being recorded, and all participants will be sent a link to view the recording in the next few days. And our speakers will also be sharing a PDF copy of their slides as well, which will also be emailed to you. And we do encourage your questions. We will have about a 45-minute presentation from our speakers, and then we will have time for questions at the end. So to submit your questions, we'd ask you to use the Q&A feature at the bottom of your Zoom screen. We will also be monitoring the chat for any questions as well. At the end of the webinar, when you are exiting the event, you will be prompted to complete a short evaluation, and we would really encourage your feedback and any comments through this evaluation. It's incredibly helpful for us to help inform our work and direct future learning opportunities like these webinars as well. Okay, so on to introducing our speakers. Chealsea De Moor is a knowledge broker with the Canadian Centre on Substance Use and Addiction. She has been with the Centre for 5 years. Her present areas of interest include impaired driving and substance use supports and services for equity-deserving populations. She has also been involved with CCSA's substance use cost and harms projects since 2017 in both research and knowledge mobilization capacities. She is presently the co-chair of CCSA's Equity, Diversity, and Inclusion Committee. Chealsea holds a master's degree in forensic psychology from Carleton University. Her studies focused primarily on substance use and mental health needs of women offenders. She is also a former employee of the Correctional Service Canada Research Branch Women's Offender Unit. Emily Biggar is a research and policy analyst at the Canadian Centre on Substance Use and Addiction. Her work focuses on trends in the use of legal and illegal substances, potential harms, and resulting costs to the Canadian economy. She holds a Master's of Public Health degree from the University of British Columbia. And with us today, we also have Doris Payer. Doris is a senior knowledge broker at the Canadian Centre on Substance Use and Addiction, where she leads the knowledge mobilization strategy for CCSA's Substance Use Trends and Early Warnings portfolio. This includes coordinating the Canadian Community Epidemiology Network on drug use and a national drug tracking working group. Doris received her PhD in addiction neuroscience from the University of California, Los Angeles, and worked as a clinical research scientist at the Center for Addiction and Mental Health, assistant professor of psychiatry at the University of Toronto, and assistant professor of population health at London School of Hygiene and Tropical Medicine before joining CCSA in 2018. So we're really grateful to have the three of you with us today. So I'll turn it over to you to get started.
Thank you so much, Claire. So I'm just going to share my screen and I'll have everyone confirm that they can see my slides. I can't see anyone's face, so I'll need just a verbal okay.
Looks good, Chealsea, thanks.
Thank you so much, Claire. All right, so as Claire mentioned, today we're going to be chatting a little bit about trends in Canada's drug supply, polysubstance use, and unintentional drug poisonings. So just a bit of a background on the CCSA, or the Canadian Centre on Substance Use and Addiction. So the CCSA was created by an Act of Parliament in 1988 as a non-government organization, and we provide national leadership on substance use to advance solutions to address substance use health issues. We have a variety of stakeholders, government, non-government, a variety of audiences that we tailor our products to, and we also cover just a wide range of topics and issues at the center. So as we had started the presentation, we'd also just like to take a moment to respectfully acknowledge that the offices of the Canadian Centre on Substance Use and Addiction are located on the traditional unceded territory of the Algonquin and Anishinaabe people. The Anishinaabe-Algonquin Nation have been present on and nurturers of this land since time immemorial, and we're very grateful to have the opportunity to live, work, and play here. We also want to acknowledge Indigenous peoples as traditional knowledge keepers, and that our society greatly benefits from the sharing of Indigenous peoples. So we'd like to just offer everybody a moment to reflect upon where they're joining from today before we get started. Okay, so in terms of our objectives, I think Claire covered this quite nicely, but we're going to begin by having a bit of a conversation around stigma and how we can improve the way we talk about substance use and unintentional poisonings to kind of do our own part to combat stigma in our day-to-day lives. And then we're going to jump into describing some data trends in substance use and unintentional poisonings, specifically focusing on some health risks and harms related to the co-use of opioids and stimulants. And we're also going to talk about some of the reasons why folks might use these substances together. And lastly, throughout the presentation, we're going to sprinkle in some resources, both stigma and data focused, so that folks have information that they can take away in addition to the PDF slides that we're going to share for you. So let's dive in. We're going to start with a note on language. So this conversation really centers around the issue of stigma. And what is stigma? So stigma is any attitude, belief, or behavior that discriminates against people. And we know that many conditions are stigmatized, but substance use is actually one of the most stigmatized health conditions. So what does substance use stigma look like? It can present in different ways, but some examples would include having a prejudice towards a person because of their use of a substance, belittling a person's value based on their use of a substance, or dehumanizing someone through a label. And I'll provide some examples in a couple of slides of what that might look like and how we can adopt more non-stigmatizing language. Stigma is a significant barrier to well-being and good health for people who use substances. And so it's important for us to know that there's actually sort of a cycle that happens with substance use and stigma. So because substance use is such a stigmatized condition, people who use substances experience stigma from society, from sometimes their friends and family, and stigma can even be internalized. And those experiences of stigma can culminate in negative feelings, right? Internalizing shame, fear, and self-doubt. People start to believe the things that they're told when they experience stigma. And oftentimes folks will continue to use substances to cope with those negative feelings. So you can appreciate why this cycle could just continue to perpetuate itself, right? You have someone who uses substances, they experience stigma, they then experience those internalized sort of negative feelings that then perpetuates the continued use of substances to cope. And so they're kind of stuck in this cycle of ever experiencing stigma. And I think we really wanted to note that we feel as though a lot of the reasons for why some of our more progressive approaches to maybe supporting people who use drugs or preventing harms, such as harm reduction approaches, those might not land or haven't been adopted necessarily across the board because there is a deep-seated stigma that is very prevalent for substance use. And it's not just on the individual level. We know that stigma has permeated our systems. And so it is something that takes a lot of effort to combat, and we can't do it alone. But this is one of the reasons why we think that it takes some time to get these progressive, effective approaches in place, because we are up against this moral issue of stigma and how people feel about those who use drugs. Now, having said that, there are tools that we can use, even just in our day-to-day lives, to help destigmatize the conversation around substance use and do our part to help folks feel more included. And so one way we can do that is through person-first language. And person-first language acknowledges someone as a person before we describe their personal attributes or health conditions. So an example of this would be many times folks will refer to someone who uses drugs as a drug user. And that is a term that we would like to move away from because it really centers their substance use as their identity. It places their behavior before their identity. And I think we know that people who use drugs are people, and we shouldn't be defining them solely based on that behavior. So instead of saying that someone is a drug user, a more appropriate term would be a person who uses drugs. It's very specific and accurate and intentional. The next line down, so these are some common terms that people use to describe people who have a substance use disorder. Terms that now make me cringe, but I'll say them just for the purpose of this presentation. So calling someone an addict or a junkie, they're incredibly pejorative terms. People who use drugs have noted how stigmatizing and harmful this language can be. So something we could use instead would be a person with a substance use disorder. Now, it's important to know that not everyone who uses drugs has a substance use disorder. So there is a distinction there. So when we talk about someone that has a substance use disorder, we're talking about someone who's on that very far end of what we would call that spectrum of substance use. They're experiencing incredibly high risks, social, health, economic, to their lives as a result of their substance use. And so just to remember that people can use drugs across that entire spectrum, from not using at all to having low risk use, moderate, all the way up to substance use disorder. So just to note that it looks different for everyone, and that this particular term, we leave that for folks that would meet those criteria at that sort of higher end of that continuum of use. So the next term is very much rooted in sort of stigma or stereotypes and misperceptions around what we know about substance use. So this notion of being clean or being dirty based on whether or not you consume substances. So this concept of my cousin got clean because they're not using substances. This very much reinforces that stereotype or that caricature that we have, that people who use drugs are unhygienic, they don't take care of themselves, they might be unhoused. But the reality is people who use drugs look like you and I. They can be any different, they can live any different life, and not everybody who uses drugs is going to fit that very stereotypical kind of perception of what some people think it looks like. So we're trying to move away from that language of clean and dirty to something a little bit more accurate. So instead of saying my cousin got clean, we could say my cousin is not actively using drugs. And this is very clear and accurate, and we don't need to use sort of a symbol or a euphemism or anything to explain what we mean. We just say what we mean. Now, the next three are very kind of nuanced examples that we felt we should bring up in the context of this presentation. So for a very long time, folks referred to a drug poisoning as an overdose. That's a term that many of us have heard and we probably still use in our day-to-day lives. There is an active effort to move away from the term overdose and adopt the term drug poisoning as an alternative. And the rationale behind this is that people are being poisoned by our drug supply. It is incredibly toxic and contaminated. And this just kind of, it's that effort to acknowledge and reinforce just how dangerous the situation is and that folks are being poisoned by the substances they're consuming. Many folks don't necessarily know what they're consuming because of the situation with the supply. So that's an important kind of move that we're trying to make in adopting that language. The next is a movement away from the term accidental drug poisoning to adopting the term unintentional drug poisoning. And this has been a move we've seen in the poison prevention space and also the impaired driving space. An accident insinuates that nothing could have been done to prevent the experience of the drug poisoning. But we know that there are tools at the individual, the social services level, the political level that can be used to help mitigate the risk of drug poisoning. So by adopting the term unintentional or intentional in place of accidental is a very deliberate move to reflect the fact that there are things we can do to prevent these situations, but it's a matter of making those services and supports available and at our fingertips when we need them. And the last note I'd like to make is on the terminology licit or illicit drugs and moving towards adopting the terminology regulated or unregulated. And this, again, kind of falls more around the stigma lens of when we talk about illicit or illicit drugs, we're separating them based on their status, right? Their legality. So someone who is consuming a licit drug or a legal drug like cannabis or alcohol or tobacco, we oftentimes associate that with more of a better morality, right? You're not breaking the law, so it's okay for you to do that. And it's easier for us to minimize perhaps some of the harms because we're putting that legal or illicit label on it. Versus illicit, where we're talking about the fact that the drugs are illegal. And so that inherently puts sort of a negative tone on that, right? People are breaking the law to consume these substances. That's morally unjust. And so it again reinforces that us versus them, good versus bad, criminal narrative to the conversation. There's a very deliberate move to adopt the terminology regulated or unregulated, so we can move away from that punitive element and really discuss the fact that that's what we're talking about. We're talking about drugs that are regulated by the government, alcohol, cannabis, tobacco, to some extent, a few other drugs, but we won't get into that now, versus our unregulated drugs, right? So heroin, fentanyl, anything that's not being regulated and produced by the government. So these are again, some examples of how we can choose person-first language, some of the terms we can adopt in our practice, and some of the terms you will hear us use today, and just provide you with some rationale for that. So at this time, I would love to pass it over to my colleague, Emily, who's going to bring us through a conversation on some of the trends in substance use and unintentional poisoning.
Perfect. Thank you so much, Chealsea. I think it's so important to root our conversation with kind of acknowledgement of using person-first language and just recognizing people who use substances as people first. We're going to be taking you through some graphs and some figures which show these kind of data trends, which represent people who use substances and have experienced harms. But it's so important to recognize that these are people first and not to minimize their experiences in that way. But nonetheless, We will start this part of our conversation with a kind of reality that likely most of us are very familiar with, and that is the staggering number of opioid-related harms being experienced by Canadians. So unintentional opioid poisoning harms have increased rapidly in recent years. And I've included some data from the Special Advisory Committee on Epidemic of Opioid Overdoses to illustrate this, looking at the rate of opioid toxicity deaths, particularly the unintentional ones, over the past few years or so. And just for some precision around terminology, when we're talking about an opioid toxicity death, this refers to a poisoning or toxicity where at least one of the substances involved was an opioid. So there are two key takeaways here. The first being that the rate of these deaths has almost tripled since 2016. So by 2021, the last year that we have full data, we find that over 21 Canadians died each day due to unintentional opioid toxicity, and that's almost one person per hour. The second key takeaway from this slide is the second line. We see the number of deaths involving fentanyl. So it started from about 50% of these deaths in 2016 and has increased to almost 85% of deaths in the most recent years. So when we're talking about opioid poisoning deaths, we're really talking about those being driven by these powerful synthetic opioids that are found in the unregulated supply. Next slide, please. Now, another really important part of this picture is the involvement of other substances, in particular stimulants. So again, we're looking at the rate of these unintentional opioid toxicity deaths and the proportion that also involves stimulants, which is between 50 and 60%, since this data has been kind of collected and collated starting in 2018. Not shown on this graph, but we can also consider the reverse situation. So that is an unintentional stimulant toxicity death. So a toxicity death in which one of the substances was a stimulant. And we find among these that 85% of stimulant toxicity deaths also involved an opioid. So what this tells us is that people who are dying from substance poisonings are often using opioids and stimulants together, but it is really the synthetic opioids, in particular fentanyl, that are the central driver of this harm. Next slide, please. So unsurprisingly, this concurrent rise in opioid and stimulant-related deaths is mirrored by a lot of the trends we see in terms of utilization and resulting costs to the healthcare system. So here I'm presenting updated estimates from the Canadian Substance Use Costs and Harms Project, which presents costs of things like hospitalizations, ED visits, paramedic services, and other direct healthcare costs, which are directly attributable to opioids, cocaine, and other CNS stimulants, which is primarily methamphetamine. So these estimates suggest, again, somewhat unsurprisingly, that opioid-related healthcare costs have and continue to account for the majority out of these three substances, and costs continue to rise. However, we do see a very stark increase, particularly for those methamphetamine, other CNS stimulants over the years, really corresponding with the increased toxicity of the unregulated drug supply. So in fact, harms have been increasing at a faster rate for these substances compared to opioids. Next slide, please. Now, at the same time, despite these increases in harms and costs, the overall population prevalence of use of these substances is either low or declining. So for stimulants like cocaine and methamphetamine, we see between 1% to 3% of the general population using the substances, which has been relatively stable or just slightly increasing over the years. For opioids, in terms of general population prevalence of use of both prescription opioids and other types from the unregulated supply, course, this general population stat is being driven by the use of prescribed pain reliever type opioids. We see that the prevalence has almost halved between 2007 and 2020. So it's kind of the direct opposite of what we see in terms of the increase in harm for other trends. And again, reiterating that the central driver of these poisoning related harms relates to the use of drugs from the unpredictable, unregulated supply amongst certain population groups. Next slide, please. So in order to kind of narrow our focus to look at what is happening in these population groups, to really help tease apart these harms and better understand what's happening and how steps can be taken to reduce them, we're going to be presenting some data from 2 of CCSA's substance use trends and early warning types of projects. So I'll just summarize these projects before I get into the bullet points on these slides. So the first is what we call CENDU, or the Canadian Community Epidemiology Network on Drug Use, which is a sentinel surveillance system, which is made up of representatives from across Canada who will collect and collate information on drug harms collected from local data sources, like coroner's data or poison control centers. Also pulling data from anecdotal reports from folks who are working directly with people who use drugs, as well as people who use drugs themselves. And the second project that is informing some of the information we're going to cover is called Community Urinalysis or Self-Report Project, or CUSP, which is another surveillance system engaging people who are using harm reduction services across Canada in collecting information on the substances they expect to use via a survey, and comparing that with the information on substances they've actually consumed, detected via analysis of a urine sample. So to really get at what people intend to use versus what is actually coming up in their drugs. So from these 2 data sources, and over the course of the subsequent slides in this presentation, we're going to be looking at the facts pertaining to how stimulant is prevalent in these specific populations, which tend to be at greatest risk of harm. And among these populations, that the preferred stimulant tends to be methamphetamine, though there is some variation across regions in Canada. Further, as stimulant use is quite prevalent, so increasingly is the concurrent use with opioids. However, not all of this concurrent use is intentional. Whether use was intentional or not, the harms tend to still be driven by the unpredictable nature of the drug supply. So we're going to, well, I say we, but it's Doris is actually going to break down each of these points in greater detail in the subsequent slides. So hand it off to Doris.
Thank you, Emily, and thank you, Chealsea. So yeah, as Emily mentioned in the previous slide, one of the reasons we're seeing high rates of harm despite low prevalence in the general population is that surveys of the general population don't necessarily capture those at the highest risk. And so we know from national survey data that past year use in the general population is about 2% for cocaine and 0.5% for methamphetamine. Meanwhile, our CUSP study that Emily just introduced showed that among people who use drugs, stimulants were actually the most common. So the chart is showing substances detected in urine, which suggests recent use. And nearly 2/3 of participants had stimulants detected compared to 1/3 of participants or less for any other substance. Next slide, please. And when we asked participants about the preferences, they reported preferring methamphetamine to cocaine. And again, compare this to the general population where cocaine is more prevalent than methamphetamine. It is the other way around in the sample of people who use drugs. And the reason this matters is that methamphetamine compared to cocaine is associated with a steeper rise in deaths in recent years, a steeper rise in healthcare costs, as you saw in one of Emily's slides. There is some anecdotal evidence that meth manufacturing methods are tied to health deterioration, although this point needs more evidence. And various drug supply data sources show that fentanyl co-occurs with meth more often than it does with cocaine. So taken together, we can see that people who are already at high risk of unintentional drug poisoning are also using the riskier substances. And next slide, please. So I also wanted to make a note that the presence of these substances in the drug supply varies by region. So this is data from Health Canada's Drug Analysis Service, or DAS, which analyzes samples of drugs seized by law enforcement. And so here I'm showing the presence of cocaine, meth, and fentanyl detected by DAS in different regions of the country. So BC, Prairies, Ontario, Quebec, Atlantic regions, and the territories over the past couple of years for each. And so we have cocaine in blue and meth in green and fentanyl in yellow. And what I want to point out is that there's more meth than cocaine in the prairies. But as you move east to Ontario and the Atlantic provinces, there starts to be more cocaine than methamphetamine. Quebec doesn't fall into this pattern. Quebec is an exception. They have more methamphetamine than cocaine. And in BC, it's actually fentanyl that's the most prevalent in the supply. And there's no difference between the two stimulants. All right, so another factor that Emily introduced was that concurrent use of stimulants and opioids is on the rise, and this is contributing to the increases in harms that we see. So as an example, in our CUSP study, more than half of participants said that they used both opioids and stimulants in the previous 3 days. And other studies have highlighted some of the reasons why people would use them together. So these reasons range from modulating the highs, so to enhance the effects or counteract the effects or imitate effects or prolong the high, to things like self-medication and sexual enhancement. And here too, I want to emphasize that these are not all the reasons that people would concurrently use opioids and stimulants. These are just some of the most common ones. But these reasons also vary by population. And in some cases, they're really also just practical, like using stimulants to stay awake to guard your stuff if you're unhoused, as an example. All right, next slide, please. So yeah, it makes sense in some cases to use these substances together, but many people actually don't intentionally use them together. Instead, they use them unknowingly because they're hidden in another substance that they're trying to use. And this is due to the unpredictable nature of the unregulated drug supply, which by definition has no quality control. So we see a lot of adulterants and contaminants or substances cut with other substances. So this is an infographic we created with Sendu and drug checking programs back in 2019. I hope it's evident that it's meant to look like the nutrition facts on food packaging that tells you all the ingredients that are in the product. So here we're showing all the substances that turned up in samples that people brought into drug checking services as opioids or stimulants. And you can see that what their drugs actually contained ranged from various super high potency opioids to benzos to cutting agents like plaster. And in stimulants, these unexpected substances ranged from opioids to levamisole to cutting agents like detergent. And again, a note here that for drug checking services, finding unexpected opioids and stimulants was actually fairly rare, but it does exist. So for example, data from Health Canada's Drug Analysis Service shows us that fentanyl is in over 3% of samples that also contain cocaine or methamphetamine. So it's a small percentage of samples that contain fentanyl, but it does happen. Next slide, please. And so even if it's not showing up in stimulants that often, fentanyl does appear unexpectedly in many substances. So here I'm showing data from the CUSP study that Emily introduced, where we asked people what people who use drugs, what substances they used in the past 3 days, and also analyzed the urine to see what was actually in their system. And not surprisingly, these don't match. So what I'm showing in this graph is the percentage of people who had opioids detected in their urine. So these opioids are fentanyl in dark blue and heroin or morphine in light blue. And these are the results at different study sites during different years of data collection. And so the total height of the bar is the percent of participants who had fentanyl detected in their urine. The solid portion of the bar is people who also reported using fentanyl, so they knew it was there. The hatched portion is the people who had it in their urine but didn't report having used it, so they used it unknowingly. So you can see that surprise fentanyl does happen, and that also is driving a lot of harm. Next slide, please. And what's worse is that even when people expect to use fentanyl, the fentanyl is cut with other substances. And this has been the focus of a recent Sendu alerts and bulletins, which you can find on the CCSA website. And most of the attention recently has gone to benzodiazepines, nitazines, which are ultra high potency opioids, and xylazine, which is another tranquilizer that we're hearing a lot about these days. And again, there's evidence that people use these substances alongside opioids intentionally, especially benzos, but there is also evidence that people don't mean to use these substances concurrently, but they are, because that's what's in the unregulated supply. And so that is adding even more risk and harm. Next slide, please. So this is just a quick aside. In parentheses, I had shown you surprise fentanyl and substances. And so this graph shows unintentional benzodiazepine use, again, from the CUSP study. So it's the same setup as the fentanyl and heroin graph. So again, the total height of the bar is the percentage of people who had benzodiazepines in their urine. The solid portion is those who expected it. The hatched portion is those who didn't. So you can see that it's quite a few people in some regions who had unexpected benzos turn up. In fact, across all the sites, 1 in 3 participants had unexpected benzos in their urine. Next slide, please. And so, yeah, coming back to the idea of fentanyl co-occurring with other substances. I know this is a heck of a graph, so bear with me. What I'm showing you here is, again, DAS data. So samples of drugs seized by law enforcement over time from January 2020 to December 2022. And so here, the total height of the bar is the number of samples analyzed that month that contained fentanyl. The gray portion is the fentanyl samples that contained only fentanyl, or fentanyl plus something that we're not talking about today. The hatched portion is samples that contain fentanyl plus one of the adulterants that we're talking about. And so at the top of the bars is fentanyl plus benzodiazepines. So NMB here stands for non-medical benzodiazepine, and different variations of benzos and nitazines. And at the bottom, we have fentanyl plus xylazine and different variations of xylazine, benzos, and nitazines. So what I want you to take away from this graph is, well, a couple of things. So one is that right around when the pandemic started, at the beginning of 2020, there started to be more fentanyl being seized. So the total height of the graph or of the bars went up, and also more co-occurring benzos, nitazines, and xylazine over time since then. But you can also see that these patterns are always shifting. So for example, at the end of 2021, beginning of 2022, there were a lot of benzos in the supply, but that proportion seems to be decreasing again as you move to the right of the graph. So it shows both the adulteration and the volatility of the unregulated supply. And there are a number of caveats with DAS data that I'm happy to talk about, but in the interest of time, I'm going to throw it back to Chealsea to take us home.
Thank you, Doris. That was wonderful. So what does this all tell us? Basically, it tells us that this has incredibly wide-reaching impacts, right? So as had been mentioned earlier, a lot of the folks who are consuming the combination of substances we talked about are already at highest risk for harm. So we're just going to see a continued marginalization of and risks to people who use drugs. And that includes sort of those stigma-related elements about sort of preferred behaviors, the type of substance you use, how you use it, if that impacts your healthcare utilization. So lots of continued risks until we're able to figure out more of a solution to manage that unregulated supply. And we're also still going to see great social and economic harm. So our cost and harms data, as well as other death data, shows us that there are increasingly high numbers of deaths, many at a young age. So this has many impacts on our economy, but also just on personal lives lost. It's just a very sad reality of what's happening right now. We also see a high burnout and secondary traumatic stress among service providers. So the CCSA ran a study in recent years looking at harm reduction workers. And we actually found that levels of burnout and stress were actually higher among harm reduction service providers than hospital healthcare workers during the first few waves of COVID. So that should give you a bit of a landmark in terms of how difficult this job is right now and how much vicarious trauma and stress they're experiencing in their work. And as well, just the continued impacts on healthcare and criminal justice. So Emily noted the costs and just the impacts. And so we expect to see these continue so long as the supply isn't regulated. So in terms of what this might mean for policy or program considerations, there's quite a few things that we can talk about. So first is ensure that harm reduction services are actually tailored to the needs of people who use stimulants and or opioids, which is increasingly the norm. And it's interesting, I saw an article recently around some of the supervised consumption sites out in BC and how folks feel like they're really missing the mark right now because a lot more people are smoking opioids and of course stimulants, and you're not allowed to smoke on supervised consumption sites. It's injection based only. So this creates kind of an issue with not meeting the needs of the folks who need the services. So being more nimble and adapting as we see those trends in the toxic supply change could be very helpful as a solution here, a part solution. Other factors to consider is whether co-use is expected or not. So as Doris alluded to, the risks and harms change depending on the combination of substances you're using, as well as your route of administration. So we need to consider those elements when we're creating and tailoring our services. And we also just have to consider the personal goals of folks who are using substances and what they're looking for with their support. So not everybody is willing or able or ready or wants to completely cease their use of substances. So focusing on reducing use, reducing the toxicity when they do use is going to be an important tool to have. And also perhaps exploring availability of pharmacological treatments for stimulant use disorder. So we see that there's pharmacological interventions we can use for opioid use disorder, opioid agonist therapies, things like that. So exploring other options for stimulant use disorder to support those folks as well. This also tells us that we probably need an update on our drug poisoning education and our response protocols in the context of polysubstance use. So most of our protocols right now are centered around the assumption that we're dealing with opioids or fentanyl. And so our response protocols, let's say when we see somebody in a poison situation, a drug poisoning situation, our assumptions might not hold true when we respond. So we may need to kind of tailor our response protocols as well when we're responding to address the fact and meet the need of the fact there are other substances involved. There's also upstream solutions to reducing toxicity of drug supply that we can explore, which still continue to evolve. And as well, just on more of an individual side of things, and what we can do is starting to integrate and continue integrating non-stigmatizing language into practice. So working with people who use drugs to ensure that we're meeting their needs and we're using language that is inclusive to them and it's non-stigmatizing. And really the only way to do that is actually by engaging those audiences, people who use drugs, and asking them, how can we speak about this in an appropriate, non-stigmatizing and empowering way? So these are kind of just a wrap up of our key messages here. So just that non-stigmatizing language really helps to frame substance use compassionately and as a public health issue. Substance use risks and harms are increasing due to concurrent use of multiple substances. And we know that now this includes the co-use of opioids, stimulants, and benzodiazepines, but also the unintentional co-use of contaminants. And we know that there are some newer kind of synthetic substances that are making their way into the market that we're now concerned about, some of those high potency synthetic opioids, the benzodiazepines and xylazine. And that harm reduction and prevention efforts should take concurrent substance use into account, right? So making sure that our programs are tailored to meet the needs of the concurrent use and are responding to the potential harms and risks that are going to come from those situations. So that's that's it for our presentation. We have a couple of resources we wanted to share just around drug trends, drug checking data, and then there's also some resources around youth, talking to youth, how to help young people, and then of course a language primer around stigma that CCSA had done in partnership with the Canadian CAPSA, which is one of our peer-led organizations that specializes in substance use stigma. So we'll leave it there and maybe pass it over for some Q&A.
Perfect. Thank you so much for those great presentations, Doris, Emily, Chealsea. A really interesting and I think compassionate look at this issue. We have such a variety and such a large audience here today with people from across healthcare, injury prevention, community level care, law enforcement as well. So I think the interest in this, I think, really speaks to the wide-reaching impact of substance use across health and society and the economic impacts as well that you mentioned, and hopefully points to an interest in that multi-pronged collaborative program and policy level approach that you outlined that we need for reducing harms and supporting recovery as well. So thank you very much for this presentation. We do have a couple of great questions that have come in through the chat. I'll start with one that spoke to some of what you were talking about at the beginning of the presentation, Chealsea, around destigmatizing language. There was a question around the word sober and the language of sobriety. So can you speak to that language and what's sort of appropriate with the language of sobriety?
Yeah, of course. So something I didn't touch on in the presentation, but I think it's really important to acknowledge right now is that there are certain terms that people will use. Let's say a person who uses drugs might reclaim a term that we may not use as somebody who's not part of that community or having those experiences. So I'll use this term as an example. We wouldn't use the term addict to describe someone, but there's a lot of individuals from the substance use community who have reclaimed that term to empower them, and just because they feel as though that is the best term to describe themselves. But it doesn't mean it's appropriate for us to necessarily use that term. So I think sober or sobriety is kind of in that gray spot. So I think a lot of people who use drugs use that term to describe themselves, and that's okay. And I think the best thing to do is ask someone when you're speaking about it, what is their preferred way of talking about it, but just recognizing that it's an ever-evolving context. And I think when we talk about adopting person-first language or more inclusive language, it's a journey. And you're probably going to make mistakes. We all do. Even those of us who are in this space make mistakes, right? So lead with the compassion, ask folks what's the best, most appropriate term. And when in doubt, you can always defer to the terms we've used, right? So it's always safe to say, if you're not using drugs, you're just not using drugs. And I would say that's the best way to go. But again, respecting that like some groups and communities might reclaim some of these terms for their own kind of empowerment, and we still have to respect their autonomy as well. So I really hope that answers, and happy to provide some more information if needed.
Great, thank you, Chealsea. We had another question looking to clarify some of the language around concurrent use. And I know, Doris, you spoke about how in some circumstances that concurrent use is occurring unintentionally. Can you speak to really what you're talking about when you're talking about concurrent use that perhaps happens in an intentional context? And is that co-use, or is it happening over a period of time? Just sort of what that looks like.
Yeah, and there's obviously a lot of nuance to that term that we glossed over for the sake of this presentation. So yes, it can mean that someone intentionally takes the two substances together at the same time, or one before the other, or even days apart. So in the CUSP study, for example, people were only asked if they had used each of these substances in the previous 3 days. And so it could have been anywhere in that span of 3 days. And so, yeah, this is an important nuance to look into for the sake of the point that we were trying to make, that, this concurrent use that we're seeing in some of the, tox data, could be intentional and could be unintentional, but like the specifics of the intentional use is another area that, yeah, I think deserves a lot of attention. And Emily, I don't know if you had any words to add about the CASP study.
I think that's fantastic response. I think you've highlighted that, yeah, it's worth further teasing apart. We don't really have a standardized indicator of polysubstance use or sometimes even concurrent use. So just being, yeah, mindful about the data gaps and filling in what we can with the data that we do have available to us.
Great, thank you. There was also a question about the analysis of use trend slide, and if it was possible to separate the data out or speak to data trends that you've perhaps identified about what is regulated and what is unregulated opioid use. Is that something you could speak to today?
Yeah, so I think this relates to the slide about population prevalence of opioid use. And so that's a piece of work, as I briefly mentioned, that comes from an input to the Canadian Substance Use Costs and Harms study. And those prevalence estimates are a fantastic piece of work. It's actually led by our colleagues at the Canadian Institute for Substance Use Research. And it's essentially a product of some fairly complex modeling, which I will go into detail unless you're looking to take a nap, but it combines some information about self-report survey data, so primarily from the CADs in earlier years, the CTADs and so on, as well as some supplementary information from hospitalizations and the drug analysis services of Health Canada's drug analysis service as well. So for background, those are all of the inputs into that prevalence slide, which I think is just the next couple slides down.
Oh, sorry, next one.
Here.
How did that?
A few slides down. Long story short, it's based on the survey data, which is the primary input into those estimates. It's not possible to tell whether the use was from kind of the regulated or it was prescribed, or whether it's from the unregulated supply. That kind of information is not kind of collected in a standardized way over the years to enable us to capture it. However, we do know from the death data, for instance, looking at opioids that are detected among drug poisoning deaths, that the vast majority are not of pharmaceutical origin. They're coming from from the unregulated supply, and that is really driving the harms. Though we don't have a very good measure of capturing that population prevalence of use from sources like surveys. So not something we can separate, but we generally kind of have an understanding of the source of the harms there. I hope that helps to answer.
Yeah, it seems from the chat that this is an analysis that would be of interest. There's another question here noting that it would be interesting if the graph on expected and unexpected benzos was stratified by those who expected fentanyl and benzos or just benzos, since the use of counterfeit Xanax can be different across geographies, and just asking if that analysis had been explored. Did you want to add anything additional to that question, or I can jump to it?
Yeah, I can just speak a little bit. So we haven't separated out the analysis for that specific research question. It is a very interesting one. I think you could probably look to drug checking data as well to look at kind of different expected benzo or expected fentanyl samples to get an idea of what people are expecting to use for those very specific combinations as well. So we did provide some links to drug checking, public drug checking data that you could look to as well for some answers.
Perfect. I'm going to turn to a question that was submitted during registration. We had a lot of great questions submitted there as well. And you had mentioned a few links at the end there, and I believe also in the presentation as well, you'd mentioned drug checking services, which offer people who use drugs with information on the contents of their drugs. And outside of these services, what is available for people who use drugs to access information on the contents of drugs? that they're using. And we also had a related question about drug testing strips and their accuracy for detecting the presence of fentanyl and other substances as well. Would you be able to speak to kind of programs or services that are available, perhaps also to rural populations, people who aren't in cities and close to these brick and mortar services?
Sure, yeah, I just don't know if I have good news. I mean, so for people who aren't in one of the locations where there are established drug checking services, the options are very few. So that's why it's so important to try and scale up drug checking services, because, you know, it's really the best shot we have at knowing in almost real time what's happening in the drug supply. So there are a few mail-in services, and people are trying out mobile services. Like a few services have vans that they take to different events, or, you know, different ways of courier of samples to the laboratories. But yeah, it is right now very limited, the organizations that can tell you about the contents of your drugs. And I think it is important to keep that in mind as we think about harm reduction options, and that this is really something that we should have in as many places as possible, just you know, to increase equity of access and an equity of knowing what you're putting in your body.
Mm-hmm.
I forgot what the second half was of the question.
The second half was just asking about the efficacy of drug testing strips.
Right. So yeah, the drug testing strips, it's interesting because many people expect fentanyl in their drugs these days. Like they're looking to use fentanyl, and so to have a test strip that tells you there's fentanyl in your fentanyl isn't that helpful. The drug checking services are trying to validate, so they do like an on-site, more sophisticated test of a sample, and then also a test strip, and they send it in for confirmation sample. So there are ways to make sure that the test strips are telling you what they are supposed to. But again, like in the current drug supply, it's almost expected that fentanyl will be around. There are also benzodiazepine strips, but those, from what I understand, are finicky, and you have to be really well trained to use them. So this isn't something you can you know, pick up and try to use efficiently. And I heard there's also xylazine strips, but those haven't been validated yet. So, you know, the idea of strips is popular because they're cheap and you can hand them out, and it doesn't involve, you know, you can give them to people as opposed to, you know, providing a service where you have to take a sample of, you know, a substance from the unregulated market and carry it around and test it. So the strips are convenient, but they're also limited in a lot of ways. So I think, you know, the yes, no answer won't do much. I think we need more sophisticated analysis.
Mm-hmm. Great, thank you. And in our registration, we also had a number of questions about youth trends and data and approaches, and you highlighted a couple of resources at the end of your slides there. I just wanted to give you an opportunity in case there are any trends or approaches that you want to highlight as part of the data that you presented today around approaches for youth, or you know, implications for practice and other pieces there.
Emily, do you want to go first?
All right, take it away, Chealsea. And
it's nothing groundbreaking, but I think young people who use opioids, that population is an incredibly vulnerable, very, very difficult population to work effectively with, because we're just not, a lot of organizations aren't set up to do that work well. So what I would say is that with young people, it's just very important to share the facts, share the information, have conversations early. Some of the resources that we shared are actually from one of CCSA's flagship projects where we worked with young people with opioid use disorder in BC and Alberta and actually co-developed a lot of system navigation resources for them. So these are young people who are actively using opioids and experiencing significant harms. And so the resources that came from that are really centered around how to get the right care, how to ask the right questions, and really set up young people to be successful in their journey. So I think if there's anything to say about it, I would just say that our death data points to people losing their lives at a younger age. So I think that just underscores the fact that like this is a population we need to look towards, and getting data from young people can be difficult, especially when you're talking about poisoning. So just to say that it's a group we need to do more work with, but we need to do that work very carefully and kind of with them in mind. So
great points. Okay, so we continue to get in a few questions, and we will endeavor to share answers with you via email, and we'll be following up with all of the registrants of this webinar with a sharing of the recording, the slides, and we'll also get our speakers to provide some feedback on the questions that have been submitted. But I do want to say a huge thank you to you, Doris, Chealsea, Emily, for your time today, for lending your expertise and your time to this webinar. It's been incredibly insightful, and the feedback has been great. So thank you all for attending as well. And please fill out that evaluation on your way out, and have a great afternoon. Thank you, everyone.
thank you to the Parachute team.
Thank
Take
you.
care, everyone.